First of all, I would like to thank the European Society for Pediatric Urology to allow me to present this lecture talking about bladder function after in utero myelomeningocele closure. All this data has been produced by myself and by Dr. Marcela Leal da Cruz. So I would like to acknowledge her participation in this lecture too. Myelomeningocele has been known to be treated according to the two-hit hypothesis. That means the damage to the nerves from the disease itself, but also from the possible damage during the exposition of the nerves to the environment of uterus. So this was the rationale for in utero repair. And it was not until the publication of the MUMS study, the management of myelomeningocele study, in which a randomized trial of prenatal versus postnatal repair was shown, and it was noticeable the improvements of in utero surgery, especially in regards to the need of ventriculoperitoneal shunts. There was a reduction in only 40% of patients required a shunt, whereas in the postnatal group, it was 82%. There was also an improvement in the motor status of patients at 30 months. In Brazil, our group in São Paulo at Federal University of São Paulo was available to treat patients according to this protocol, and already 4 cases had been done before the MUMS. So immediately after the publication, we restarted right away our protocol under the leadership of Professor Antônio Moron, fetal medicine, and Professor Sérgio Cavaleiro, which is the head of neurosurgery of Unifesp. And this paper shows how active this group is in fetal surgery. This is a publication from 2018 in the British Journal of Obstetrics and Gynecology, reporting in 6-year periods from 2011 to 2017, 237 patients treated. Total surgical time was 120 minutes, and these are data related to the obstetric parameters. This is also a recent publication, just recent, from 11th of September of 2020, from the same group here in Brazil, and it's the first case report in the literature of fetal surgery from occipital encephalocele performed by Professor Sérgio Cavaleiro. Here you see a patient in utero with a huge encephalocele. Here you have a drawing showing this, and the same principles in cases used to operate in utero myelomeningocele repair were done here. You have here the pictures illustrating the treatment in the paper just published. So we had in Brazil the ideal scenario for in utero repair. We are in a university hospital. That means we are already used to research and to medical education. We were already established Spina Bifida group with more than 20 years collaboration right now. The precursors of fetal surgery in Brazil were in this institution. It's a nationwide experience because at that moment in 2011, it was the only hospital in Brazil which was available to treat those cases. And very nicely, patients continued to do follow-up with us in a yearly basis. So this is the group that I mentioned, Professor Sérgio Cavaleiro, head of neurosurgery department Unifesp, Professor Antônio Moron, head of medical and obstetric and medicine, fetal medicine, Professor Alexandre Lourenço, head of section of orthopedics, pediatric orthopedics, and I'm the section in the pediatric urology. So, and they have an advantage. Here is in my office, you see that just beside my room, where I see cases, I have a urodynamic facility with my nurse following all the cases. That means that urodynamic evaluation is a continuation of our appointment and is done right away after consultation. This slide I presented last year in the meeting in Lyon. This is the literature. You have very limited literature in fetal surgery of myelomeningocele. On the left side, you see the cases, serial cases, which were retrospective. And on the right side, you see the prospective studies. You see we were able to contribute with the very first papers in the literature, followed by this paper from the moms, which we consider the urological moms. There is a paper from Zurich with 8 cases only, comparing 8 cases. We had other studies here, and this was we have published this paper last year with 100 cases. I will also review the literature from this year and show and discuss the data. Well, already in 2015, we were already able to show that we could, through treatment, adequate and early treatment, improve and reduce maximal detrusor pressure by high-risk patients, as here according. And this is possible because we try to categorize the patients very from the beginning and to treat them adequately. This is the first paper, prospective paper, presented in the literature. It was presented in 2015 in the Neurology and Urodynamics, in which we have presented our first 19 cases. In the same year, Brock and collaborators presented the urological part of the MOM study. So they consider in their analysis as primary outcome death or need of CIC by 30 months. And then they established the criteria to start CIC in the postnatal group. And the study has something interesting because the 3 main centers which performed the study of moms, after that, the patients were sent to variable places, to very local urologists. So this made very difficult to have a planned protocol. And when they say patients were reviewed at 12 and 30 months visits, they don't say explicitly if they were done in the mom's urologists or in the local urologists. And also, we do not know exactly when urodynamics was performed, at what day, and not the mean age at urodynamic evaluation. And again, this factor is very interesting because all the information has to be related to the local urologists. So when they conclude their data, they reported that the primary outcome, that means either CIC or death, which was only 1 case by each group, but they have very limited urodynamic data, just this leak point pressure higher than 40 centimeters, but you don't see more informations besides CIC on 30 months, which they reported as an advantage to the prenatal operation. At that same year, we report our first 50 cases of patients prospectively assessed. And very interestingly, we present this categorization of bladder pattern by Dr. Marcela Leal da Cruz, in which we subdivide the bladder according to urodynamic condition. It's very important to outline the high-risk patients, those who are overactive with the detrusor leak point pressure at higher pressures, more than 40 centimeters of water, of high filling pressures, also above 40 centimeters of water. But it's very important to define this group, the incontinent pattern, those patients that had some overactivity, but they leak at low pressure, or they are stable but leak at low pressure, below 40 centimeters of water, because this group represents for the future a potential problem in terms of continence. You have also patients, we have underactivity of the bladder, no contractions and high residual volumes, and this normal pattern, which is the stable cystometry without leakage, urinating at the end. In these first 50 cases we presented, seen initially at a mean age of 4.8 months with a mean follow-up of 14 months, you see this categorization represents more than 50% of our series. That means 56.2% were categorized as high risk, whereas 35% were incontinent pattern. Incontinent in this definition of urodynamic evaluation, because you cannot say incontinence for a baby of 4 months, but you can predict the pattern in the future, and you will follow these patients according to urodynamic data, which makes our study unique, because you are taking in consideration urodynamic data only. And subsequently, last year, we were able to report the first 100 cases of prospective analysis and to have this question answered. Is there an improvement in bladder function? So this is our patient participation. We started in 2011. In 2012, we have more than 10 cases a year. Then 2013 and 2014, we have been operating a basis of 22 patients a year. That means almost 2 cases a month. And then up to 2018, when we reach 100 cases. Again, you see here, there is always this trend of 52% high risk categorization of the bladder, 25% as incontinent pattern, underactivity just 5%, and normal pattern only 14%. And very importantly, when you look for patients who have hydronephrosis or have vascular reflux, according to the underlying bladder pattern, you see that 3/4 of patients who had some degree of hydronephrosis were in the high-risk group, whereas almost 2/3 of patients who had vascular reflux, they were also in the high-risk group. That means it's very important to categorize and to treat from the beginning very objectively, because the complications, when they do occur, hydronephrosis, bladder thickening, vascular reflux, they will be mostly in the high-risk group patients. Came out also, this paper is the only paper reporting on bladder function after the Phetoscopic procedure. That's a group from Texas, and they reported on 14 cases, and very interestingly, again, overactivity of 64%, like our data, impaired compliance in 37%, vascular reflux in 20%, data very similar to ours. And very interestingly, in this paper, in the discussion, they also make a criticism, the same criticism we did for the MOMS trial, because of its heterogeneous urological follow-up, whereas the Federal University of São Paulo has published its single investigator prospective urological assessments in those papers that I had already presented to you. And I would like also to stress that this procedure, the Phetoscopic procedure, has been introduced by also a Brazilian doctor, Dr. Denise Pedreira, which is a friend of mine and works also in São Paulo, and it has been reproduced in various institutions. We were interested to define if gestational age at birth has any role in later neurogenic bladder pattern, because there is a higher incidence of prematurity. So in this paper, we present also in 2015, considering that the MOMS has shown almost 80% of prematurity, we looked in our patients according to gestational age at birth and subdivided in 2 groups, having 34 weeks as a cut. So we had the group 1 less than 34 weeks, 42 patients, and group 2 more than 34 weeks. That means 37 patients. And when you look in the data in terms of mean age at urological evaluation, the incidence of urinary tract infection, occurrence of hydronephrosis, they were very comparable, no statistical significance. And also, when you look here, the incidence of high risk, it was quite similar, no statistical significance. So we could conclude that gestational age at birth has little impact on bladder pattern. This data reinforce the need to follow this population very closely. So we consider it also in this publication, 2018, only patients with more than 5 years of age. That means objective analysis for urinary and fecal continence. So we were able to study 14 patients who at that time were already 5 years of age at least. And again, the high risk pattern was predominant, the incontinent pattern about 28%. And at that moment, already 3 patients had to go to surgery. When you look for continence, you see 85% at 5 years of age were on CIC. Only 3 had no urinary leakage. That means only 21% had no urinary leakage, even considering CIC, and were exactly those cases operated. 78% were still on diapers. 57% performed retrograde fecal washouts, and 78% had fecal loss, but those data seem not to affect the self-esteem of this population. So in conclusion, in this series, at the age of 5, almost 80% had abnormal bladder patterns. The need for surgery after 5 years was 4%, 85% still on CIC, only 21% with no leakage urinary, and fecal incontinence of 78%. Well, the MOMS has presented this data with the same objective, in which they select patients at 6 years of age and checked renal ultrasound, video urodynamics, and defined as primary outcomes the occurrence of CIC, vesicostomy, dilatation of the urethra, or augmentation cystoplasty. At the same time, again, the continence, and if they were on CIC, diapers not on CIC, and if they were able to void volitionally. But if you read carefully this publication, when they say they have contacted the family at 6-year-old child or children, they say literally, families were offered a single comprehensive study, or alternatively, a telephone interview with parentally reported urological outcomes. And they don't say exactly how many were seen indeed, and how many were just interviewed according to the parentally reported urological outcomes. They say they were offered a video urodynamics, but since they were not in the institution, you don't know where and performed by whom or when. Also, when they are defining the primary outcomes, they say they were interested to check how many had CIC, but there is no strict criteria set for beginning CIC. It was just according to the treating physician, that you don't know if it is a urologist, a pediatrician, so that this information is missing. And for sure, this will compromise data. So they found statistical significance of the occurrence of CIC with a lower incidence of CIC in the prenatal data, and they report it's an advantage. But again, if you don't have any strict criteria for CIC, how can you judge this data? And again, they report its advantage the ability to be voiding volitionally, but you don't know exactly if this patient has residual volume or not. And then for those who are used to treat patients in neurogenics, what is the possible role of Uroflow in this population? Especially when you look here and you see that the only, in the urodynamics, one of the possibilities, which is statistical significance, which is the residual volume in the prenatal, there was a difference. Prenatal was 125, postnatal 167 mLs. But in the practical world, what does it mean? 125 of residual volume or 167 mLs of residual volume both require CIC. And that's why their conclusions were very modest. They concluded in their paper that both children were in diapers or in CIC. They were more likely to void volitionally, but again, we don't know if it's correct. They were about to void because they had residual volume. And their conclusion, their main conclusion, is already more in accordance to our data. Urological outcomes alone should not be the sole impetus to perform in utero close of myelomeningocele repair, because they are not so evident as they stated in their first studies. So we wanted to do a retrospective control study because at the moment we started our in utero, we could not randomize anymore in our institution. So we looked back for patients who were treated postnatally since 1999, compared to this group after 2011. But to make it more homogeneous, because the initial presentation from postnatal varied a lot. So we defined a subgroup of G2, which was group 3, for patients presenting only below 12 months of age. And this has been published last year in the Journal of Urology. What we did, we reviewed the first 3 urological evaluations of those groups, recorded medical history, physical examinations, findings, and radiological workup, because the protocol is strictly the same from 1999 until now in our institution, in our group. You see, there was a variation in the prenatal according to the postnatal. But when we select patients under 12 months, you see that age at first presentation was quite similar, 5 months for group in utero, 4.2 for group postnatal. There is a higher incidence in the postnatal population for UTIs, but they have a longer follow-up that could explain this. But the other parameters like hydronephrosis, thickening bladder, occurrence of vesico-urethral reflux, you see, are pretty the same. And again, when you look urodynamic data, you see the in utero had a higher incidence of overactivity according to the other groups of postnatal that we could not explain. But when we compare according to the 3 urodynamic evaluations, comparing intrautero with the general group 2 of postnatal, you see occurrence of high-risk groups at the first and the last urodynamics are pretty similar. The incontinent pattern as well, very similar according, no statistical significance in difference, except in the first analysis, which you have a better improvement of the postnatal of higher incidence of normal. But again, you see that there was no big difference. When you compare, this is the best comparison because you are comparing postnatal with less than 12 months of age at first presentation, and you see very comparable data. When you see all this information in charts and you separate them according to the pattern of the bladder, you see treatment over time for both groups, there is a decrease in the prevalence of high-risk pattern and an increase of normal patterns, whereas the incontinent pattern and normal pattern remained more or less the same. So we could conclude in this control study that in utero myelomeningocele has limited benefits to bladder function, and early categorization of bladder pattern is essential, and hypocontractile and incontinent patterns do not tend to change over time. So we looked specifically, and this is the very first publication reporting in the natural history of in utero myelomeningocele patients with the incontinent pattern. That means sphincter deficiency with leakage below 40 centimeters of water. So we could identify 30 patients, that means 25% with this pattern. We looked in the clinical data, and from these 30 patients, 23 had at least 2 urodynamic evaluations, and follow-up was almost 30 months. And here you see, according to the number of those 23 patients, the maximal pressure at leakage at first and last urodynamic evaluation, and the final bladder pattern categorization. All were incontinent or all had pressure below 40 centimeters of water. And then you could notice that are cases that have increased, they have changed the pattern. And we could conclude that 42% of patients with low DLPP, the incontinent pattern, will keep this pattern in this follow-up of 30 months, but if leakage occurred below 30 centimeters of water, 70% remain the incontinent pattern. This is the case that you can predict the need for a major urinary reconstruction in the future. And this is the patient that is not being counted in the various series reported. Take a look at this last very nice paper presented by the group from Zurich, the group from Rita Gobet, Maya Hurst, and this presented by Luca Mazzoni. Well, they define neurogenic lower urinary tract dysfunction based on micturition behavior or urodynamic findings. Normal bladder was those who had stable detrusor during filling and an effective detrusor contraction leading to voids, normal compliance, normal capacity, normal bladder sensation, and no residual urine. But in this definition, they don't consider at which pressure he is voiding or having some leakage at the end of cystometry. And if you look in the first paper they present, comparing only 8 patients, you see there was a preponderance of normal bladder function. But this was done in the second day of life. If you look for the data they present at 6 months of age, which I consider more appropriate in terms of the reality of the bladder, which approaches our data, you see they have 50% of neurogenic dysfunction. And what they consider normal bladder dysfunction, there should be half of this group leaking at low pressure. So their data is very comparable to our data, and you see the neurogenic patterns will increase over time in correspondence to normal patterns. And very interestingly, they report that the complications, bladder wall thickening, upper tract dilatation, vesico-urethral reflux, they occur mostly in these patients with neurogenic lower tract dysfunction. And this is exactly what we had presented in our paper in the British Journal of Urology last year. So they confirm the early published favorable preliminary results, but they demonstrate that the positive effects remain limited. I would say very limited, because already in 6 months, you see no advantage in terms of pattern, and you should consider also this incontinent pattern. So where are we today? Today we follow 122 patients, surgery at 25.6 weeks, born at around 33 weeks. You see, our mean follow-up right now is 23.5 months. Very low incidence of ventriculoperitoneal shunt, only 7.5%, which is a major advantage for this population. You see, the patterns, overactivity is very prevalent in our data. And again, high risk is more than 0.5% or 50% of the patients, 25% incontinent. This is the whole population. And if you look in the incidence of surgery, you see we have operated so far at this follow-up 6.6% of our data. Vesicostomy performing 3 at a very early phase, because it's when you have to do something that your patients who are not responding to anticholinergic and CIC, and the other indications, bladder augmentations. We use the left antegrade colonic stoma. We'll show you in a while. So if we look specifically to the high-risk patterns, which are 61 cases so far, and look only those who have 42 or more urodynamic evaluations. So I'm considering 44 patients. You see a higher incidence. 62% will have a febrile UTI in follow-up. Thick wall bladder, 35%. And overactivity in these populations is higher, almost 80% of data. But if you treat them adequately from the beginning, 40% will turn to a low pressure bladder. So you can improve the bladder characteristics of this population and bring them, according to the categorization, to a normal in the last evaluation, as shown here in this curve. And we have looked at 156 urodynamic evaluations, as here shown, and you see from the high-risk pattern, there is, according to time, an increase in the low pressure bladders. That's what it means, but for sure, there is an improvement on that. But incidence of surgery in this population, 61 cases, is higher. We have to treat 6 of 61 cases with surgery. That means almost 10%. So in this follow-up that we have, which is still limited, the incidence of surgery is not that low as people mention, and we are able to report it prospectively. We do it in our different way of doing an augmentation. This is the procedure that we described in the year 2000, the British Journal of Urology, and has been reported in various textbooks of urological surgery. And the advantage of this technique is that we detubularize the ileum segment and make a flap in the median part of the ileum. And from this flap, we'll make a tube, we make a reservoir, and you make a serous line tunnel as a continence mechanism. This procedure can be done for augmentation or substitution. Here is the procedure concludes after creating the reservoir and the tube. We open widely the bladder. This is one of all these patients that we report, a very thick wall bladder. And we perform with Proland sutures this valve mechanism, showing that the tube will be facing downwards. This angulation is essential for the good result. We have to place a suture here in the dome and to make here a fixation of it in the abdominal wall. And we also add the Yasha procedure, which is we cross 2 flaps of rectal muscles to place the tube inside to avoid leakage. As you see, the operation can be done by a very small incision. And again, we use the same principle to perform the left ACE. This is what we published in 2005 as the Macedo-Malone procedure. And we just put the left colon here outside of the body, do a transverse flap, a tube, do a valve, bring back. You can do it by a very small incision and very nice and cosmetical result. I'd like to thank the organizers, the European Society of Pediatric Urology. I've been following all those meetings since my very first meeting in Istanbul in 1999. And I'm really thankful for the opportunity that I have been through all those years to present our data, to discuss with you our experience. And I would like to invite you to come and visit us in São Paulo. Besides our university, we have this Spina Bifida hospital where we follow 3,000 neurogenic bladder patients. And every Friday, we perform a major reconstruction in this hospital with our teams that most of you recognize, Dr. Sergio Ottoni, Dr. Gilmar Garrone, Dr. Marcela Leal da Cruz. And this group has been together for more than 20 years. And for sure, all this data has been produced by a group, not solely by me. I'd like to thank you again for this fantastic opportunity to talk about our experience, and I'll be available to answer your questions and discussions. Thank you very much indeed.